This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Conference. Our speaker this morning, Dr. Godley Jack. Godley is a second-year fellow in our clinical track, native of Maryland, did medical school at the University of Maryland, did his residency at the University of North Carolina, and is going to be talking to us today about the heart's friendly neighbor to the north, the aorta. Godley.
All right. Thank you, Dr. Williams. Good morning, everyone. Again, my name's Godley Jack. I'm a PGY5 cardiology fellow here at Emory. And today I'm going to be giving a talk on a topic that I think is extremely important, and that is pathologies of the ascending aorta. And I chose this topic specifically because as a general fellow, I've been exposed to a number of patients with different pathologies of the aorta, but I thought that I needed a deeper understanding of not only the different etiologies of ascending aortic aneurysms and dissections, but deeper understanding of how we treat those etiologies differently. And so I'm hoping I can get you guys excited about this topic and that each of you can take away something new that you can incorporate into your clinical practice. So with that, let's move forward. Okay. All right. So my objectives today, I'm going to start by discussing the basic anatomy of the aorta, both at a gross level and microscopically. I'm going to move on by describing three very important etiologies of aortopathy, and that's those associated with vasculitis, those associated with a genetic syndrome, and those associated with congenital heart disease. And there are a few categories we're going to leave out for the purpose of time. We're going to incorporate some short cases into this to highlight the specific processes. We're going to describe a basic diagnostic approach towards the end, and interspersed within this talk, we're going to talk about some medical and surgical management. Why is this important? Why should you pay attention? In whether you're a general cardiologist, an interventionalist, an imager, a congenital cardiologist, you are going to see patients in your clinical practice that suffer from this disease. And whether that be the asymptomatic young female that presents to your office with an incidentally discovered aneurysm, a patient with a very strong underlying family history, or a patient that has already been diagnosed with aortic disease and a status post-surgery, it's going to be important in your clinical practice to understand the differences in the etiologies and some of the umbrella recommendations of how to manage these people, both pre and post-op. I think integral to, if you want to take as much away from this talk as possible, and to really integrate the concepts at a deeper level when it comes to the pathologies of these diseases, we have to have a good understanding of the basic anatomy of the aorta and its layers. So the aorta is comprised of three basic layers: the tunica interna, tunica media, and tunica externa, also called the adventitia. And the purpose of the tunica interna is really to provide a space for smooth, non-thrombotic laminar flow. And it's going to be composed of a monolayer of endothelium supported by a basement membrane. And just outside of that basement membrane, we have the internal elastic lamina, which is a fenestrated membrane that has different numbers of holes in it, depending on what artery you're in. But those holes are or fenestrations are going to allow for the crossing of water, nutrients, and ions across the layers. Outside that, we have the tunica media, and the tunica media is a thicker layer composed largely of vascular smooth muscle and a lot of rich elastic tissue. And its purpose is going to be to allow for stretch and recoil of the aorta in a way that stores and releases potential energy in the form of pressure from the heart. The tunica externa is going to give us some more backbone, and it's comprised mainly of collagen, mast cells, and fibroblasts. We're going to come back to this a little bit later in the talk, but deficiencies in each of these layers are going to lead to pathology in specific cases. It's important to remember the outer half of the aorta is fed by penetrating arteries called the vasa vasorum, and the inner half, or the luminal half, is just diffusion of nutrients from the lumen. The gross anatomy. So on the picture on the right, so the aorta originates from the sinuses of Valsalva, and the sinuses are bordered externally by the outer wall, the outer pouching of the proximal aorta of the sinuses, and then internally by the upper layers of the aortic valve. The sinus then transitions to the ascending aorta at the level of the sinotubular junction. And then we have the more straight ascending aorta, the aortic arch, the descending aorta, and then the abdominal aorta. So I have pictures here to demonstrate. And then the ASE has previously used population data to publish norms as far as the diameter of the aorta. And we can see as we get older, the variability amongst the population of the aortic diameter changes. And we're going to talk about how, about different ways to calculate aortic diameter. But I had this included just for reference. The aortopathies we're going to talk about, I mentioned briefly, vasculitides, specific genetic syndromes, and congenital heart disease associated. What we will not talk about today for the sake of time are infectious aortopathies such as syphilis and root abscesses, mechanical or iatrogenic aortopathies such as seen in trauma, in the cath lab, or in the OR. And last, we're not going to talk about atherosclerotic aortopathies. So this is not a talk on aortic imaging. I could give a whole separate talk on that subject, but I think for completeness sake and for the purpose of highlighting the tools that we have to make our diagnosis, I wanted to touch briefly about what we have at our disposal. So chest x-ray is generally, a lot of times, incidentally, it's going to be what we have to incidentally discover some of these diseases. It has a very low sensitivity and specificity for aortic disease, but oftentimes we can identify mediastinal widening. A lot of times we can identify the right border and the aortic arch, and sometimes the left border of the aorta, but this is not going to be something that we use on a regular basis. CTA is going to be one of our workhorses, and it's shown to have 92% accuracy for diagnosing abnormalities of the thoracic aorta, with non-con CT being much less sensitive and specific. Echo is going to be the second workhorse for making diagnosis, and it's able to visualize the aorta and its major branches, and it has the major benefit of being non-invasive with almost no risk. MRI, it's going to be more expensive, takes longer, but the sensitivity and specificity is arguably slightly better than CT and TEE. So we're going to move on to talk about specific pathologies now that we have a quick intro. And the first branch of aortopathies I'd like to discuss are those associated with congenital heart disease. And the vast number and the most well-known is those associated with the bicuspid aortic valve. Now, the bicuspid aortic valve is bicuspid aortic valve in 90 to 95% of cases is going to be someone who's born with 3 cusps of the aortic valve, but with fusion of 2, making a functionally bicuspid valve. In much more rare cases, some people with bicuspid aortic valve are actually born with only 2 cusps, and we're going to talk about that a little bit more later. But bicuspid aortic valve is one of the most common congenital heart diseases. It's present in 1% of the population, and it's usually typified, the clinical presentation is usually typified by valve stenosis and insufficiency. But really important for this talk, 50 to 87% of patients with bicuspid aortic valve also have dilatation at the ascending aorta. And so what we've begun to do is, when we're characterizing bicuspid valve, also characterizing it as a valvular aortopathy, and we're going to talk about that in a few slides. There is increased incidence of aortic dilatation amongst patients with first-degree relatives. We'll touch on that as well. And there is also an association with coarctation. So this is a case of a 34-year-old female. It's a very interesting case. So this is a 34-year-old female that presented. She had been trying to get pregnant for more than 12 months. And at some point, she had a positive pregnancy test and presented, and it was found that her beta HCG was out of proportion to what they would expect. So what she was ultimately found to have was a right ovarian cystic mass that was resected. And in the process of undergoing the surgical workup, she had an echo that showed a dilated aortic root. So after having it resected, her beta HCG remained elevated, and she was found to actually be pregnant. And so she underwent counseling and decided to move forward with the pregnancy despite having this dilated ascending root. So she underwent screening by TTE every 4 weeks. She had extensive genetic counseling about the risks, and she was started on a beta blocker, and she was actually able to deliver a healthy child. This is an MRI image, a sagittal MRI image of her aortic root, and she had a 5.4 centimeter dilatation. This was the first case in the literature where a pregnant patient with a dilated root was able to deliver successfully to term. So the pathophysi. I'm sorry. That was the. Yeah. So I'm sorry. This lady was. I forgot to mention. She was known to have a congenitally bicuspid valve. I forgot to mention that. So this was a bicuspid valve case. So I want to talk about the etiology of the bicuspid aortic valve. There's a lot of research done on this, and it's really a two-pronged approach. So the aortopathy seen in the bicuspid aortic valve is caused by both intrinsic or genetic aortopathy, and then more debatably also abnormal hemodynamics across the valve. So a phrase that was coined in the 1980s, I believe, was cystic medial necrosis or degeneration. Necrosis being somewhat of a misnomer because there is no actual necrosis. It's actually non-inflammatory loss of vascular smooth muscle that leads to damage of the integrity of the wall of the aorta itself. And what we also see is fragmentation of elastic fibers and increased basophilic ground substance in the cell-depleted area of the ascending aorta. And the reason being is we think that a lot of the same genetics that cause the bicuspid aortic valve also lead to these deficiencies in the wall or the cellularity of what makes up the wall itself. Other things that have been known to be contributed, the same deficiency seen in Marfan's, actually, a deficiency of fibrillin 1, which tethers the vascular smooth muscles themselves. There's known to be patients with bicuspid aortic valve and that aortopathy are known to be more likely to have deficiencies in fibrillin 1. Also, there's increased activity of matrix metalloproteases, which degrade the extracellular matrix. And so what we've seen is that, again, the aortopathy and bicuspid valve is present at a cellular level. And I included this slide just to highlight some of the mutations that have been identified at a higher frequency in patients with bicuspid aortic valve. As I read about this topic, the hemodynamic changes in bicuspid aortic valve it's somewhat debated whether this actually contributes or not, but the theory is that a combination of shear and tensile stress over many years leads to both a stretch and a dilatation of the aortic root. And so in patients with stenosis, the high velocity and viscosity of the blood leads to shear stress. Tensile stress from increased stroke volume with aortic regurgitation leads to tensile stress. And then the stress over time recruits more matrix metalloproteases and other cellular mechanisms that lead to aortic injury. And so the aorta over many years goes from being like a fresh new sock to an old withered sock that you have in your closet that's lost its elasticity, and so aneurysms can develop. I thought this was a really important slide. So in the past year or two, there was published an international consensus statement on the nomenclature of bicuspid aortic valve. And in this paper, they touch on how we characterize bicuspid valve with not only the valve itself, but the aorta as well. And so bicuspid aortic valve, the valve itself can be classified in three ways. 90 to 95% are going to be the fused phenotype, in which you're born with three cusps, but the commissure is fused at one of three. And so you have different subcategories of that are pictured here. And this is going to be the phenotype in the vast majority. And again, that's called the fused type. The two sinus type is going to be present in 5 to 7%. And again, these are people that are born with only two cusps. And then the variable type, partial fusion, it's kind of a combination of the two. It's very, very rare, and they actually weren't able to give a percentage on it. Now that we were able to classify the valve itself, next we're going to classify the aorta and the major phenotype. And one thing that I want to highlight for the purpose of this talk, bicuspid aortic valve tends to affect the ascending aorta much more commonly than the root. So in bicuspid aortic valve, you tend to see ascending aortic dilatation, not dilatation of the root. That's present in 70% in the ascending phenotype, 20% in what's known as the root phenotype, and the variable is the extended phenotype where you see dilatation of both. And so I include these slides to say, in 2021, when you're characterizing a bicuspid aortic valve, you should be able to characterize more than just the valve. So on the left, so this is kind of the algorithm that we're using now. On the left, we're specifying the type and phenotype of the valve based on what we just talked about. We can characterize the raphe and their symmetry and the presence or absence of calcification. And then lastly, you also want to characterize the aortopathy, whether it's present, absent, and whether there's the presence of coarctation or not, and whether it's severe. These are all things you want to include in your note when characterizing someone with a bicuspid valve. Other congenital anomalies that are associated with aortopathy, but much less so and much less studied. An aberrant right subclavian artery, a right aortic arch, and coarctation of the aorta are also associated. And in doing my reading, a lot of these diseases have overlap with other genetic syndromes that we're going to talk about later. And it's believed that there's ultimately, the mechanisms and the pathophysiology, there's overlap between a lot of these. The next major class of aortopathies I want to discuss are those associated with a vasculitic process, or the vasculitic aortopathies. And this was a slide borrowed by Dr. Laiko, in which we've summarized all of the vasculitides. And as we know, vasculitides are inflammation of the vessel, and they're going to be characterized by large, medium, or small. And the large vessel vasculitides are generally the ones that we think about affecting the aorta. And what we're going to talk about today is Takayasu's arteritis and giant cell arteritis. So Takayasu's arteritis we're all familiar with. And Takayasu's is thought, the underlying etiology is not entirely understood, but it's thought to be related to cytotoxic T cell inflammation, cytotoxic T cell mediated inflammation that begins at the tunica externa and works its way inwards and causes eventual granuloma formation. The clinical presentation, it's important to remember, has both an acute and a chronic phase. So like many vasculitides, the acute phase is going to be typified by weight loss, night sweats, malaise, generalized symptoms that eventually, as the inflammation or as the vasculitis progresses and stabilizes, leads to a chronic phase where we get most often stenosis that causes end organ damage and symptoms related to that end organ. One thing I didn't know until I read about this, there are two distributions that are characterized. One is the more well-known Japanese distribution, which affects the thoracic aorta and its branches. and the second being the Indian distribution, which more often affects the abdominal aorta and the renal artery. Diagnosis is generally going to be made by clinical features, and there's not much of a role for inflammatory markers, although they can be used to increase or decrease your clinical suspicion. The prevalence is most likely in women in 80 to 90%. The age of onset is less than 40 years, and there is a worldwide distribution with a stronger prevalence towards the Asian population. What I found, anywhere from 1 to 2.6 per million cases was the incidence. So this is another case I wanted to highlight. So this is a 25-year-old female that presented with weight loss, constitutional symptoms, anemia of chronic disease, and elevated inflammatory markers. Her workup eventually led to a CTA, which revealed aneurysms of the ascending and descending thoracic aorta and the abdominal aorta, and a thickened carotid wall. She was eventually diagnosed with Takayasu's based on the clinical presentation and imaging, and she underwent treatment with initial steroid therapy and methotrexate, and her symptoms got better after 18 months. She originally did not present with any end organ damage, and the plan was just to monitor. At that point, the ascending aortic aneurysm was 40 millimeters in width. Her symptoms returned 18 months after therapy, and she was switched from methotrexate to tocilizumab. But she underwent an MRI that showed that the ascending aorta had significantly increased in diameter to 54 millimeters. And I have that pictured here. And I also wanted to highlight how good of a tool MRI is in not only diagnosis, but monitoring. So she underwent a hemi-arch repair, and the surgical specimen revealed adventitial fibrosis, mural thickening with adventitial small vessel vasculitis. So another important slide. So this was a cohort of 60 patients diagnosed with Takayasu's arteritis based on clinical presentation and imaging. And the cohort is from 1970 to 1990 at the National Institute of Allergy and Infectious Disease. And this is a really important slide for several reasons. So first, what they see by and large is that Takayasu's arteritis presents with stenosis rather than aneurysm. And when aneurysm is present, it's very likely to be in the aorta itself rather than its branches. The next important takeaway from this group was that when the disease is present in the aorta, you can see it in the aortic arch, the abdominal aorta. Really, all parts of the aorta were affected. And I think the biggest takeaway from this cohort, 92% of patients presented with either left, right, or bilateral stenosis of the subclavian artery. And I think when we take a step back and look at the big picture, and we're coming up with our differential diagnosis for aortopathies, it's really important to know what the most common phenotype are for specific diagnoses. And when you're suspecting Takayasu's arteritis in a young female that comes to your office, it's unlikely to be Takayasu's if there's not stenosis involving the subclavian artery or one of the primary branches of the aorta. And it's also less likely if they don't have stenosis at all. So that was an important takeaway. Management is largely going to be with immunosuppressants. So long-term corticoids plus or minus other immunosuppressants like biologics. MRI and CT are going to be our workhorse for diagnosing and monitoring. And we want one of those at least yearly thereafter. Surgical management is going to be key once the dilatation reaches a critical threshold, but it's important to remember for Takayasu's arteritis, for surgical sake, we don't want to intervene in the acute inflammatory phase. because it leads to friability of the arterial tissue that can make surgery and wound healing more complicated. For stenosis, you want to be able to consider endovascular repair, stents, and grafts for short segments. We'll touch briefly on other inflammatory aortopathies because they're less common. Giant cell arteritis is similar, has many similarities to Takayasu's, but the main difference being that it affects a different demographic. Usually women above the age of 50, it's a 3-to-2 predominance of female to male. And the incidence is 20 cases per 100,000 persons. It's a large vessel vasculitis that usually leads to stenosis of the secondary and tertiary branches of the aorta, but very rarely can also affect the aorta itself. And actually, aortic aneurysm and dissection are reported in about as many as 18%. So not as many as Takayasu's arteritis, but it can affect the aorta. The recommendations for revascularization are about the same as Takayasu's. And then lastly, a few others that I read about briefly, Behçet syndrome and ankylosing spondylitis can also affect the ascending aorta, but even less more common. The last group we're going to discuss before we wrap things up and talk about how to put this all together are aortopathies caused by specific genetic syndromes. And this is going to be probably our longest and most complicated section. And I thought this section was harder because it really entails diagnosing the syndrome first and understanding its manifestations. But the caveat being that as an adult cardiologist, when these patients come to you, they're usually going to have the diagnosis already. So the first and probably most well-known and studied is Marfan syndrome. And Marfan's is a syndrome caused by deficiency over 600 mutations in the gene encoding the fibrillin-1 protein. And that's a large glycoprotein that gets excreted into the extracellular matrix and is really important for the intrinsic structure of not only the aorta, but multiple connective tissues in different systems. And it's going to manifest as abnormalities in the microfibrils that are found in the elastic fibers in that second layer of the aorta called the tunica media. And that's going to lead to multiple issues. So I added this slide to, again, go back and highlight understanding the aorta itself and what composes it helps me know why Marfan syndrome affects the aorta. It's the tunica media and the loss of elastic fibers. My fresh, brand new sock from Target has become an old, dingy, raggedy sock that is no longer able to do that healthy stretch and recoil. And that's what we have in Marfan syndrome. So again, I'm going to highlight these are syndromes and they're mainly going to be diagnosed by clinical, your clinical gestalt and based on the presentation, but there are multiple non-cardiac manifestations, mainly of the musculoskeletal system. So you're going to see pectus deformity, scoliosis, myopia, ectopia lentis, lots of things like that, and an increased presence of pneumothorax. The vast majority of Marfan's patients, because of that lost integrity of the ascending aorta, they're going to manifest with dilatation of the aortic root and the ascending aorta and type A dissections. That's the most common presentation, the cardiovascular presentation, and the major cause of morbidity and mortality in Marfan's patients. I added this slide to highlight the prevalence. So this is a study in 2001 done at the University of Amsterdam, and they took 52 patients and with diagnosed Marfan's and followed them prospectively. And they looked at aortic dilatation-free survival. And you can see that just by the age of 25, more than 80% of these patients have developed dilatation of the ascending aorta. And it really just highlights how penetrating that mutation is. So this case itself was one that we saw here at Emory. It was a 47-year-old male with a 10-year history of hypertension that was well managed on medicines. And he presented with palpitations and ultimately had an echo done that showed a 5.1 centimeter dilatation of the aortic root. And he had no other abnormalities on imaging, no other family history, no other significant abnormalities that we could find. He generally did well. I included this case specifically to highlight that 25% of Marfan's patients are thought to develop their syndrome as a consequence of sporadic mutation of the gene encoding fibrillin 1. So these are from the 2010 guidelines on how to manage Marfan's patients with thoracic aortic disease. Class 1 recommendations are an echocardiogram, and this is pretty this is going to be pretty consistent across a lot of the aortopathies, but we're at time of diagnosis, you want to get an echocardiogram and usually like a CT or MRI to rule out other aortic disease. And then 6 months thereafter to make sure that the aortic root is not dilating significantly more. Thereafter, annual imaging should suffice unless you see something that tells you as a cardiologist that you need to do more frequent surveillance. So if the maximal aortic diameter is more than 4.5 centimeters, or if the diameter is showing significant growth, you can do more significant monitoring. Class 2A for women that are contemplating pregnancy, you want to be more careful. And so when that diameter exceeds 4 centimeters, it's reasonable to undergo prophylactic surgical replacement of the aortic root. And then lastly, if the maximal cross-sectional area in centimeters divided by the patient's height in meters exceeds 10, that's the point at which you can also consider surgical repair. And they added that because a lot of patients with Marfan's can develop complications at a smaller size. Surgical management. So in 1968, two physicians, Dr. Bental and Dr. De Bono, came up with what's now called the Bental procedure, in which you have a graft that replaces the ascending aortic, the root in the ascending aorta. And it's a valvulated tube by which we explant the native left and right coronaries and re-implant them into the holes in the valve. And this really changed the outlook on our Marfan's patients and gave them better outcomes. More recently, 20 years later, Dr. Tyrone David invented the valve-sparing root. And this is a way to not explant the aortic valve and replace it with a mechanical valve. We can leave the aortic valve as is, and the graft itself is sutured in a way that pulls the annulus of the aortic valve taut, so we don't get severe aortic regurg as a consequence. We're going to talk a little bit more about the indications for surgical repair in the next coming slides, but generally at 50 to 55 millimeters is when you want to consider repair. This is a study of Marfan's patients. I think it was out of Hopkins, but this is a really important study. 675 US and European patients with Marfan syndrome who had undergone aortic root replacement were studied. And this graph depicts 524 patients that had dissection. And what they found was that a very high percentage, 46% of patients with aortic dissection developed their dissection before the aortic aneurysm had reached 65 millimeters. So they concluded that this should be done well before that. So that's a large part of why we do that, why prophylactic surgery is recommended at 50 millimeters. And then another important table here, they looked at elective repair, urgent repair, and emergent repair, and saw that patients with emergent repair did much worse. The caveat that the issue with that I see, that I think if you take any surgery, whether cardiac, GI, musculoskeletal, any emergent surgery is going to have generally is going to have worse outcomes, and that's because those patients are sicker. So I think this is an important table, but just one I took with a grain of salt. And so the general recommendations are prophylactic surgery at 50 millimeters, and the earlier the better. Medical therapies, we're going to consider beta blockers and ARBs are generally recommended for the management of medical management of Marfan's aortic dilatation Marfan syndrome. Beta blockers decrease your myocardial contractility, which narrows the pulse pressure, which is thought to be the underlying mechanism. And then calcium channel blockers in animal models haven't really been shown to be of benefit. So the preliminary data isn't really there. So as of now, they're not really recommended. As far as exercise regimen, we ask our Marfan's patients to avoid contact sports, exercise to exhaustion, isometric activities, and activities that entail the Valsalva maneuver. And then, so moving on, the next aortic thing I want to talk about is Ehlers-Danlos syndrome, of which there are many types. But the type we're going to focus on today is type 4. And type 4 Ehlers-Danlos syndrome is caused by mutation in the gene for COL3A1 that causes a defect in type 3 collagen. And type 3 collagen is crucial for development or healthy growth of skin, hair, nails, and bones. And patients with this deficiency are going to develop some classic symptoms such as easy bruising, thin skin with visible veins, specific facial features. And then one thing that's very specific to this syndrome is uterine and intestinal rupture. And a lot of these patients actually they'll present with intestinal rupture before they present with arterial rupture. So again, this syndrome is going to be made, the diagnosis is going to be made clinically. Their median survival is only 48 years. And in a lot of cases, they'll come to you as their cardiologist with the diagnosis made already. But this one's more rare than Marfan's. Again, I include this slide to highlight the underlying pathophysiology here is with collagen. And the collagen fibers, we know, are crucial to the structural integrity of the tunica externa. And without that, these patients develop aortic disease. So this is an electron microscopy image of actually the dermal tissue. And the collagen fibers in the dermal tissue, you can see on the right as compared to the left, are much less organized. And we see the same in the aortic root, which leads to the damaged integrity. The presentation when it comes to the aorta largely are going to be arterial dissections or ruptures involving the thoracic and abdominal aorta. And this phenotype of Ehlers-Danlos as compared to Marfan's has much more tissue friability, which tends to cause extensive hemorrhage and poor wound healing. And this is something you're going to have to think about if you send this patient to the OR, because these patients are theoretically more likely to have surgical complications. So this is a case of a 46-year-old female who had already been diagnosed with Ehlers-Danlos, and she had a history of mitral valve prolapse, status post mechanical mitral valve, and she presented with 3 hours of non-radiating chest pain and a loud diastolic murmur. And her first imaging study was actually a bedside echo, which clearly shows a dissection flap here in the aortic root. And then when we put ultrasound on it, we see she has severe AR. And then chest X-ray done later also revealed widening of the mediastinum. So her CT revealed a type A dissection that actually extended from the flap from the aortic root all the way down to the iliacs. And she underwent root repair, ascending aorta and hemi-arch replacement, and a fem-fem bypass. And she did relatively well. This is a CT of her type A dissection, and we can see that the aortic root is also dilated. Monitoring Ehlers-Danlos is going to be somewhat similar than Marfan's. So again, at diagnosis, you want a complete image of the aorta with MRI or CT. You want to start also with an echo, and then 6 months later to assess for severity of dilatation. In this case, there are no standard protocols for monitoring thereafter. You're going to do this on a case-by-case basis. And then keep in mind, surgical complications are probably going to be higher in this patient population. Screening, I'll touch on very quickly. There are published recommendations on screening, and the class 1 indications I'll discuss. So it's aortic imaging in Ehlers-Danlos type 4 is recommended in all first-degree relatives of patients with aortic disease. And if mutations are identified, those first-degree relatives should have genetic counseling done. The last aortopathy I'll discuss is Louis-Dietz syndrome. And again, we're going to diagnose this clinically based on presentation. It's autosomal dominant. The outcomes are much, much worse. And it's really typified by a triad of hypertelorism, arterial tortuosity and aneurysms, and bifid uvula or cleft palate. And the underlying etiology is thought to be related to mutations in the receptor for transforming growth factor. And aortic aneurysms are very common in this patient population. Other features I have listed here, mostly musculoskeletal, and some other cardiac as well, atrial septal defects, blue sclera, PDA, velvety and translucent skin. The underlying etiology or mechanism of aortopathy has not been completely elucidated, but we believe that it has something to do with the interaction or the downstream interaction of the TGF receptor and the angiotensin II receptor. So a lot of these patients are going to be on angiotensin II blockers as well. And ultimately what it leads to is elastin fragmentation and aortic root aneurysm. So I want to highlight this syndrome when it comes to aortopathy is significantly more aggressive than the rest. The mean age of death is 26. So a lot of these patients don't make it to an adult cardiologist. And 98% of these patients have aortic root aneurysms and many of these aneurysms lead to dissection. The severity of the symptomatic manifestations, specifically craniofacial features, are going to be associated with more severe disease. And what the general recommendation is that once these patients reach the 99th percentile for age, aortic valve annulus reaches 1.8 to 2 centimeters, prophylactic surgery is going to be generally recommended. And these are the class 1 recommendations to consider surgical repair once it's reached 4.2 centimeters or greater by TEE, or 4.4 centimeters or greater by CT MRI. I'm just realized I did forget one caveat when it comes to imaging. CT aortic root measurement of the aorta on CT or MRI is generally calculated as an external diameter that includes the width of the vessel itself. But when we calculate aortic diameter on echo, we're generally just calculating the internal diameter or the lumen. And so that difference can be about 0.2 centimeters. So that's important to keep in mind. The last syndrome we'll touch on briefly is Turner's. We all know about Turner's. It's a 45 exo female that's missing that set exo female. So the typical features are short stature, webbed neck, and broad chest. And cardiac manifestations include a bicuspid aortic valve and coarctation. Dissection or involvement of the ascending aorta is much less common, and actually only 1.4% of these patients present with dissection, but they are 100 times more likely to present with dissection as compared to the average patient. And in a Danish study, most of these patients, 56% of these patients presented with dissection at the age of 20 to 40, and 2/3 were type A. So it's something important to keep in mind. And coarctation is also seen in 18%. They're also class 1 and class 2B recommendations on monitoring. And class 1 indications that there's evidence of a bicuspid valve, which is also seen in Turner syndrome, coarctation, or dilatation. We want to repeat our imaging every 5 to 10 years if normal, and every year if abnormal. Other genetic syndromes, much more rare, Noonan's, adult polycystic kidney disease, Beal syndrome, and Alagall syndrome also, but much less commonly related to aortopathy. Non-syndromic familial syndromes. So these are, non-syndromic familiar thoracic aneurysms and dissections. So these are specific mutations that are associated with aortopathy, but not leading to a genetic syndrome. And I have listed here a couple of different mutations that are associated. So now that we've gone through the three major groups, I want to try to put this all together and look at how we're going to think about this when we have a patient in our clinic or in the hospital that presents with aortopathy. So these are from, I think these are from the 2010 guidelines, and this is a general algorithm for how to look at, for how to manage surgically ascending aneurysms. And generally, if the aneurysm is greater than 5 centimeters, we're going to go for prophylactic surgery. If it's 4 to 4.9 centimeters with other risk factors, such as chest pain, a strong family history, or a history of a severe connective tissue disease or bicuspid valve, you want to go ahead and move forward with prophylactic surgery. And if we are 4 to 4.9, but without those risk factors, it would be reasonable to manage medically and do routine monitoring every year. Type A dissection, I'll talk about very briefly. Again, I included this because I think it's important to include when talking about the ascending aorta. But general management, target blood pressure 120 to 80, urgent emergent surgical referral, and we can use CT or MRI at pre-discharge 3, 6, and 12 months to monitor for progression. In up to half of patients at 10 years, repeat surgery has been reported to be required. So let's put it all together. So the structure of this talk was to get a basic understanding of 3 of these 5 branches of or groups of aortopathies, and then look at how we manage them differently, or how they may present differently, and how that may affect our management when we see them in our office. So I want to talk about what are the overlaps, what are the differences, and what should you do when you see these patients. So first and foremost, whether it's inpatient or outpatient, you want to take a really detailed history, which includes a detailed family history and a detailed physical exam, which is going to include measurement of pulses on all 4 extremities, listening carefully for bruits, murmurs, other abnormal heart sounds. And again, just taking a very detailed history. Imaging is going to be our next step, and TTE and CTA are generally going to be our workhorses, with TTE usually being done first. Usually with the summation of imaging and a detailed history and physical exam, you're usually going to be able to come up with your diagnosis, or at least a short differential. And usually when it comes to congenital heart disease associated aortopathies, you're going to have your answer based on the echo or based on your CT or MRI. The difference in management I want to highlight for the purposes of this talk is that when you're looking at bicuspid aortic valve, take the time to really fully characterize it as a valvular aortopathy and mention the specific characteristics of the valve itself and the aorta. So do they have the presence of aortic aneurysm or not? Do they have the typical fused form? That's what I wanted to highlight for that. When it comes to vasculitis, so ESR and CRP are reasonable to get, but they're not necessarily sensitive or specific for the diagnosis of Takayasu's. But ESR is a really good diagnostic study to get in giant cell arteritis. For vasculitis, for Takayasu specifically, it's most likely to present as stenosis. And if it presents as aneurysm, it's going to usually, that aneurysm is usually going to present in the aorta itself, the ascending aorta specifically. And generally, if you're looking at Takayasu's, it's going to involve the subclavian artery. For vasculitis specifically, it's also important to remember not to recommend surgery at the time of acute inflammation due to a higher risk of surgical complications, poor wound healing. The genetic syndromes, the thing to keep in mind in general is that they're usually going to come to you with the diagnosis, and the outcomes are generally pretty poor, and to also consider genetic counseling. Within the genetic syndromes, the things that I want everyone to keep in mind Ehlers-Danlos is known to have more tissue friability. So that's something to keep in mind. And Lois Dietz is generally treated with ARBs. Iatrogenic, we did not discuss, but that's generally looking at, again, surgical complications and complications from the cath lab. And infectious, you always want to think about as well. So syphilis and infection of the aortic root with an aortic root abscess. That's one thing we also want to consider. So in summary, pathology of the aorta, ascending aorta is a broad disease process. We have a wide differential. We want to consider the different disease processes that we talked about today, but you can also consider infectious, traumatic, and iatrogenic. The diagnosis, the first step in making it, involves a thorough history and exam, in addition to having a good knowledge base about the typical presentation of each diagnosis. CT and echo are going to be our workhorse, but MRI is also a really sensitive and specific tool that you can use at your fingertips. For bicuspid aortic valve, remember to characterize the valve and the root. For congenital disease, diagnose the syndrome first and then consider genetic counseling. And then by and large, always remember that early surgical management of aortic aneurysm is thought to or known to improve outcomes, but the underlying pathology must always be considered, as some of those pathologies may affect surgical management and outcomes. I want to acknowledge Dr. Wells and Dr. Lyko for helping contribute to my talk. And I want to thank each and every one of you for listening until the end. Thank you very much.
Thank you, Godley. Very excellent, thorough review of an important topic. I want to clarify something you said real quick, if I may, before we get to the questions. So the echo, so typically actually for echo, it's recommended a leading edge to leading edge approach for measurement. You're right that the tomographic imaging, whether it's CT or MRI, can often use an outer edge. So that it's even more confusing than you said. Sometimes they will use an outer edge to outer edge, and sometimes they'll use inner edge to inner edge measurement. So if you're getting discrepancies in your measurements, you frequently may want to clarify with the reading physician of the CT or MR which technique they're using, or obviously try to look at the images yourself in those techniques. But for echo, we generally want to use leading edge to leading edge, which sort of splits the difference essentially between those other two techniques, and it cuts down on potential artifact, because sometimes the trailing edge can be a bit of a blurry mess. So that's why still the convention is to use leading edge to leading edge for the aorta itself. For the LVOT or aortic annulus, you want to do inner edge to inner edge, but for sinuses, ascending, et cetera, you want to do leading edge to leading edge. And then in terms of medical management, the big thing I would say is, whether it's beta blocker therapy or ARB therapy, a lot of these, the benefits are theoretical, and the data doesn't always support that these work necessarily amazingly well. The main concept, though, or one of the main concepts for these patients, is aggressive control of blood pressure. We do know that when these patients with aortopathies are hypertensive, their outcomes significantly worsen. So it's aggressive management of blood pressure by any means necessary, but we generally start, as you mentioned, with beta blocker or ARB therapy because of the theoretical sort of pleiotropic effects that those medications may have. So Marcelo has a question. If a patient has a first degree family history of thoracic aortic aneurysm or dissection at a young age, should you sequence your patient for ACTA2, assuming that the first degree relative with a history of thoracic aortic aneurysm is not alive and never got genetically tested? So that's the question for you. What would you genetically test someone with a first degree relative of thoracic aneurysm? Go ahead and take it. I have thoughts. Maybe if Dr. Lyko or Dr. Wells is here, they may have thoughts too.
I'm not sure. I think so. First degree relative. I think by the guidelines, it's reasonable to refer them for genetic counseling, but I'm not sure.
I mean, Marcel didn't clarify this in his question. I guess if the patient themselves has an aneurysm, then I would be much more likely, if they have an aneurysm, they have a first degree relative who's had an aneurysm, then I think it's very, very reasonable to consider genetic testing in this patient. I guess where it becomes trickier is if you have a patient with a first degree relative and then the patient themselves has a normal aorta by imaging. I think your yield becomes much, much lower. And I'm not sure that patient I'd be particularly if there's not a known diagnosed syndrome within the family. So
my experience, hey, this is Mon. This is a great talk, Godly. So my experience with the genetic testing issue has been really quite complicated. And I'd be curious to get the opinion of our vascular experts. But ultimately you end up treating the syndrome that's in front of you, whether it's Marfan or Ehlers-Danlos, et cetera. And a lot of times the genetic testing is either inconclusive or negative. I just saw a patient this week with Marfan's with a negative genetic test, but he clearly has the syndrome of Marfan's, and that's not a rare event. And so I think you have to ask yourself, why do the genetic testing? Number one, it may guide your screening protocols to try to refine how frequent and how much you need to screen on an annual basis. And it may guide the follow-up of first degree relatives. I mean, to me, that's the essence of why we do genetic testing. But I'd like to echo what Dr. Williams said earlier about measurements. So our cardiac imagers here at Emory do inner edge to inner edge on CT and MRI. That's not uniform on radiologists across the board. But here at Emory, at Clifton, at least, inner edge to inner edge, and those are the guidelines, to my understanding, for three-dimensional imaging. When it comes to the aorta, by echo, leading edge to leading edge, exactly like Dr. Williams said, leading edge to leading edge. And the only other leading edge to leading edge you do by echo is M-mode measurements. Everything else inside the heart is inner edge to inner edge. And the last comment that I'd like to make is, anytime you see an aorta with effacement of the sinotubular junction, in other words, there's no curvature to the aorta, it's lost its shapeliness, then you got to think this patient could have an aortopathy. That's something that we see a lot with bicuspid. We see a lot with some of the hereditary aortopathies, not as much with Marfan. With Marfan, it's mostly the sinus, in my experience, that is dilated. But anytime you see the loss of the waist of the aorta, consider that you're dealing with an aortopathy, particularly in a young person.
I'll just
Go ahead.
No, go ahead, Brian.
We're probably going to say the same thing, Rebecca. This is Brian. Great job, Godly. With regards to the genetic screening, there are a few reasons to do that. And like Godly emphasized, you can get a sense for if genetic screening is going to be indicated based on your history and physical. So you want to be really thorough in terms of family history of aneurysms and dissections or early unexplained sudden cardiac death and types of situations. And then the personal history of other stigmata of connective tissue disease, being hyperflexible, hypermobile, translucent skin, eye and lung problems. And that I'm not even really talking about the vasculitis, but you can get a lot of that on history and physical too, but with respect to the connective tissue diseases. So you have a good idea even before you do your genetic screening if there's going to be a familial issue there. And as you know, and has been said, the genetics are not going to be black and white, but it's going to help you risk stratify the patient and determine how best to treat and do surveillance for them long term, and also the implications for the family members and the first degree relatives. So if you still have that phenotype, even though that genetic testing is inconclusive, I think it's still helpful. You would still treat that patient more aggressively if they were having an aneurysm or dissection at a young age, and or they had a family member. You would still do closer surveillance and more aggressive management, and that's in the guidelines too, for the patient and the first degree relatives. But if you do diagnose one of these Marfan's, Ehlers-Danlos, Loeys-Dietz, then there are very strict guidelines and protocols on how to manage the patient in first degree relatives. So I think it can be useful, but you're absolutely right that it's not always conclusive. And there's variable penetrance, of course, and there's certain genes out there that we're not testing for yet. So just because the genetic testing is negative does not mean they don't have a familial syndrome. So those are just a few other comments. Go ahead, Rebecca.
Yeah, I think I'm not going to repeat what you and Mon said. I would just say that in the setting of a patient, like I think Marcelo asked, in the setting of a patient who has no clear-cut issues himself, phenotypic or on echo, of family history, that I think to some extent is also going to depend on what that family history is. And also, sometimes I see these more anxious patients, and I think we have good genetics here, and it's useful for them to go and have a conversation with them and do a very detailed family tree and determine whether or not testing is warranted. And it might be very different if they have a family history of someone dying of a dissection at 80 versus 50. So I think using our genetic colleagues is helpful.
When you do send the genetic test, do you specify like which one, or is it just a panel? I mean, do you test for MYH11 and then ACTH2, and what do you, like, if you're not suspecting a connective tissue, sort of just like Marfan's or Ehlers-Danlos?
So the thoracic aortic, or I think it's the TAAD, it's a panel, and it includes all of those. So that's typically what they'll send off. You can order it yourself, but I prefer to do it with the genetic counseling. So it includes all the ones that you just mentioned.
Marcel, the exception is if you have a known gene in the family, right? You can ask them just to test for that specific gene,
right,
a fibrillin mutation or whatever. But right, if you're doing sort of shotgun approach, like Dr. Leko said, it's a panel that includes all the Marfan and the Ehlers-Danlos and all the known sort of genes associated with thoracic aortic aneurysms.
Right, but if the family has the known gene and you test the patient you're seeing for the gene and it's negative, then you don't need to do any additional imaging, right? You're done.
Yes, if you have good confidence that is indeed the gene that's affecting them, and again, depends on the syndrome. It's Marfan and it's a fibrillin mutation.
Sure.
And yeah, you can be like 99% sure that they're in the clear, but sometimes it's, in my experience, not always as clear.
Yeah, it's not binary, but like yes or no, but generally that's the thought, right?
Yes.
Okay, thanks.
All right. Well, thank you, everybody. For the sake of time, I think we'll all get on with our days. And thank you, Godly, for an excellent talk. And then the thanks, everyone, for the discussion afterwards.
The preceding program is copyrighted by Emory University.